to all the physicians who have joined online on this no thrombosis national workshop. Yeah. So at this juncture, let me take this privilege to welcome respected Dr. Surya Narayan Sharma sir, who is the course director for this no thrombosis national workshop for today. Sir is a MBBS MD and went on to do his DM neurology, and sir is a fellowship in stroke from NUH Singapore. Sir is a senior consultant neurologist and a stroke specialist at Apollo Hospital, Bannerghatta Road. Sir is also a Bangalore academic advisor at the Department of Neurology. Dr. Surya Narayan Sharma sir has clinical and academic interest, which includes infection, post-stroke spasticity, and stroke rehabilitation. Sir has leadership and professional roles also as a secretary of Karnataka Stroke Foundation and secretary general of Society of Neurosonology from 22 to 24. In terms of his academic achievement and research, sir was ranked as second rank in DM neurology, and 35 publications are to his name with 11 book chapters, 2 books, and 29 conference papers. Sir is also a recipient of four national level papers which are being presented. In terms of research and regulatory roles, Sir has been investigator in 5 international clinical trials, DNB Neurology Guide and Examination, QAI National Assessor for Primary and Comprehensive Stroke certification. Sir is also into social and public health contribution. Is a founder trustee of charitable trust working in rural education and health. Sir is also authored multiple Kannada book, and one of them was being awarded as Best Medical Literature in Kannada. Sir is also an author for 5 Kannada books as well. Welcome, Dr. Respected Surya Narayan Sharma sir, for a course director for this program, sir.
Thank you.
Yeah, we also have Dr. Madhusudan sir, who is a head and senior consultant neurologist and a stroke specialist as our moderator for today's program. He is attached to Esther RV Hospital, Bangalore. Sir, in terms of education and training, has done his MBBS from AIMS in 2002, did his MD General Medicine from Ramaya College, did his DM Neurology from again Ramaya College, and advanced training in epilepsy and epilepsy surgery workshop. Sir is also trained in stroke and neurology, neurosonology, TCD. In terms of professional experience, sir is the HOD and senior consultant neurologist at Sagar Hospital, former professor and HOD neurology Raja Rajeshwari Hospital from 2015 to 2020, and sir is also a syndicate member of RGUHS from 2024. Sir is a EC member of IMA as well. In terms of clinical expertise, sir's clinical expertise lies in epilepsy and refractory epilepsy, pre-surgical evaluation, VNS, stroke management and neurorehabilitation, neurosonology, TCD, carotid Doppler. And in terms of research and awards, sir has multiple national and international publications. He has been primary investigator in more than 10 clinical awards and Shining Star Award in Deccan Herald 2022. Sir was also awarded the Best Doctor Award. Welcome, Dr. Madhusudan, sir. We then have the speaker for today's session, Dr. Bharat MM, who is a MD General Medicine, Internal Medicine and DM Neurology from SGPGI. Sir is an assistant professor neurology at the SGPGI, Lucknow. In terms of professional experience, sir is assistant neurology professor in SGPGI, senior resident neurology in SGPGI again, senior resident internal medicine at BMCRI, editor of Marrow 2021, which is an online medical education platform. In terms of clinical and academic interest, sir's lies in headache disorders, neurophysiology, epilepsy, and neuroinfectious disease. In terms of clinical expertise, sir has electrophysiology as his clinical expertise, which deals with NCS, EMG, EEG, VEP, SSEP, and RNST. Intraoperative EG monitoring and botulinum toxicotherapy for migraine, dystonia, and spasticity. In terms of research and academics, sir's publication in clinical neurology and neurosurgery and the Journal of Headache and Pain International and National Conference participation. Sir is also the recipient of Best Resident Doctor Award and Best Clinical Research Paper and Paper Presentation Awards. With this, I would humbly request Dr. Surya Narayan Sharma sir to set the context for this program, and then Dr. Bharat sir to take it forward from them. Over to you, sir.
Good afternoon. Thank you for the nice introduction. At the outset, I thank Team Gennova for this no thrombosis national workshop to discuss about interesting cases in stroke. As Miller Fisher said, neurology you need to learn stroke by stroke. Actually, every stroke patient is different. Every stroke scenario is different. Guidelines are there to guide us for a particular therapy, but every patient we have to treat as an individual. We need to customize the treatment based on the patient's clinical context, clinical profile, and other things. To make stroke treatment simple and straightforward, we have organized this monthly online webinar for physicians, neuroscientists, neurology residents, wherein we are going to one speaker is going to give a case. He is going to discuss the case, and probably we can take questions in the end. Now the burning topic for the last 1 month is the new guidelines on ASAHA, new guidelines on stroke treatment, which is more rational now compared to what it was before, more practical, more realistic, and definitely it is patient and doctor friendly. So we have Dr. BK Madhusudan, my moderator for the session. He is going to join in few minutes. Is he there, Dr. Madhu? Yeah,
Not
he
yet.
will
Yes.
join. So we have Dr. Bharat, a young and dynamic neurologist from SGPJ Lucknow. He is going to discuss today about an interesting case, how he handled the case, and what are the current guidelines which are relevant to his case. So we will take up the questions in the end. So over to Dr. Bharat.
Thank you, sir. Thank you, sir. So I will be discussing the case. I thank the organizers and as well as the Surinarayan sir for allowing me to do this presentation. Sir, is the screen visible, sir?
Yes, doctor. Yes.
So I'm presenting a case of an acute brainstem stroke in a patient with rheumatic heart disease. So, a 48-year-old right-handed female presented with chief complaints of vomiting since 4 hours and left-sided hemiparesis since 4 hours and altered sensorium for 3 hours. Patient presented with multiple episodes of non-bilious, non-bloody vomitus, which was sudden in onset, occurred while resting. Family members at the same time, they noticed right-sided facial deviation. They also observed a paucity of left upper limb and lower limbs during attempted mobilization. There was a rapid decline in the sensorium over the next 60 minutes and patient became progressively obtunded. There was no history of any headache or seizures. Coming to the past medical history, patient was a known case of rheumatic heart disease, which was diagnosed in 2021, which was complicated by severe MR. The latest cardiac status was ejection fraction was around 50%. There was history of medication non-adherence since last 6 months. There were no other comorbidities, and there was no history of any addiction. The patient had mixed diet and obstetric history, had 2 live birth and 1 induced abortion. So on examination of the patient, the vitals and pulse rate was 110 per minute, which was irregularly irregular, and all peripheral pulses were felt. The blood pressure was around 144 by 84, and respiratory rate was around 24, and saturation was 95% at room air. The sugars was 147, and body mass index was around 22.6. On examination, the GCS at presentation was 7 by 15 E2, V1 and M4 with an NIHSS score of 24. Patient had a modified Rankin score of 5 as she was bedridden, incontinent and required constant care and attention. On detailed neurological examination, patient was stuporous, responding only to deep painful stimuli. Pupils were equal and reactive, fundus was normal, and there was right UMN facial palsy was present. On motor examination, there was grade 0 by 5 power on the left upper limb and the lower limb. And reflexes were 2+ on all the sides, and there was a positive Babinski extensor plantar response on the left side. On CVS examination, there was a pansystolic murmur which was present in the mitral area. The parabdomen and respiratory system examination was normal. So in view of this presenting complaints in the examination, a possibility of acute vascular event, possibility of posterior circulation stroke was kept, as the patient had presented with vomiting, altered sensorium, and left-sided hemiparesis. So we proceeded with the imaging of NCCT head, and patient presented to us within 4 hours of the symptom onset. In the initial imaging of non-contrast CT head, it showed a well-defined hypodensity, which is involving the right part of the midbrain and the pons, with no any changes of hemorrhagic conversions and no any mass effects. This was suggestive of an acute infarct, and the PC aspect score was around 6. So we kept the possibility of diagnosis as cardioembolic posterior circulation stroke, acute brainstem infarct involving the midbrain and pons, and rheumatic heart disease with severe MR, and atrial fibrillation with fast ventricular rate. So as the patient presented to us within the window period, we thrombolized the patient with IV tenecteplase 15 milligram.
Dr. Bharat, can we, see for the benefit of the students and the beginners,
Yes, sir.
you have localized the, this one to brainstem. Can you, explain little more about the severity of stroke? Because you said NIHS is 24. So MRS, baseline MRS and other things. And also because patient was in altered sensorium, the reticular activating system and other tracts were probably involved.
Yes,
So
sir.
probably can you just highlight little more on that part, please?
Yes, sir.
Yeah.
Sir, actually, first one coming to the GCS is Glasgow Coma Scale. So here we will see usually 3 responses, that is the eye opening, the verbal commands, and the motor commands. So actually the patient, as she was as stuporous, she had only eye opening only on painful stimulus, which would give a score of 2, E2, and then she had no verbal output, which had a score of 1, and M4 she had flexion on painful stimulus. So this we had, so we gave it so she had a GC of E2, V1, and M4. This indicates a severe brain altered sensorium with severe presentation, because actually the brainstem is where the reticular activating system is present. So this might explain the altered sensorium in our patient. So the second thing is the NIHS score. This is National Institute of Health Stroke Severity score. So total of 11 questions would be there, and a score of 42, total score of around 42. And we will assess the motor response, eye response, and the visual attention response, and the ataxia and the speech responses, and orientation and consciousness. Based on these assessments, we will give the scoring for each question. So we will give a score of 0, 1, 2, and 3. And then based upon the responses, we will based upon the patient condition, we will assess score for each questions, and the overall score will be calculated. So so usually NHS is more than 15, it is considered as a very severe severe stroke, and NHS less than 5, it is considered as a very mild stroke. And MRS is the modified Rankin score assessment, which has a score of around 0 to 6, where 0 is the patient is fully conscious oriented, with no disability, It basically assesses the severity of disability of the patient, and this will progressively increase the scores. As the scores is increased, the disability severity will also be increased. So it ranges from score of 0, which means no disability, to score of 6, which means death. So this patient had severe disability, which has a score of 5, and score of 5, it indicates severe disability.
Now, usually what we do at admission, the baseline MRS, which was their functional status before the admission, we sometimes take it. The
Yes.
MRS of 5 is probably at the time of
Yes, sir.
discharge or after the ictus.
Yes,
So
sir.
in this patient, probably MRS was 0
Uh,
baseline, which will
yes.
help us to guide the therapy.
Yes, sir.
Suppose patient baseline MRS was 4 or 3 plus, then
Mm.
most of the therapies are contraindicated.
Yes,
So
sir.
if it is 0, 1
Uh,
or even 2, we can consider all these things. Any revascularization we can consider.
Yes, sir.
Yeah,
Yes, sir. Yes,
go
sir.
ahead. Go ahead to that.
Baseline MRS was, yes, sir. Yes, sir. Uh, PC aspects, PC aspect score I will discuss in the later parts. So, uh, so coming to the course in the hospital, once the patient was diagnosed as an acute ischemic stroke, and then with acute ischemic stroke, and presented in the window period with thrombolized with IV tenecteplase based upon the body weight 0.25 mg per kg. However, there was no significant improvement in GCS and NHS score immediately post the thrombolysis. So, patient was planned for MR imaging and MR angiogram to proceed for endovascular mechanical thrombectomy. So, this was the MRI imaging of the patient, which showed areas of diffusion restriction in the right half of the midbrain and pons with diffusion flare mismatch and no mass effect. This was suggestive of an acute infarct. So MR angiogram, it showed a segmental occlusion of distal 1/3 of the basilar artery up to the tip. However, the bilateral PCA was visualized and it appeared normal. So here you can see the cutoff of the basilar artery, and then later you can see the PCA, bilateral PCA arteries. So as there was a basilar artery large vessels occlusion, patient was immediately planned for urgent endovascular mechanical thrombectomy in collaboration with interventional radiology department. So penumbra aspiration device was used for the procedure to aspirate the clot. And this is the image of the clot which was removed post in the procedure. And patient achieved a revascularization of TC score, that is thrombolysis and cerebral infarction score, which is used to assess the revascularization post the thrombectomy procedures. So we consider 2B, 2C, and 3 score as successful thrombectomy procedures, whereas 2A and 1, it is considered as not successful or not adequate recanalization or reperfusion. However, though there was revascularization was achieved, the post-procedure GCS was also patient. There was no significant improvement, and the patient was obtended with E2, V2, and M4 status of GCS, and NHS score was 22, and follow-up image. So we did a repeat follow-up imaging. So repeat CT imaging, it showed a reperfusion injury within the brainstem. Here you can see a hyperdensity involving the midbrain and some areas in the mainly involving the midbrain. This had to be conservatively managed, and patient was started on anti-edema measures. For the course in the hospital, like cardiology evaluation was done and ECG was done, which was suggestive of atrial fibrillation, and 2D echo was done, which confirmed rheumatic heart disease, severe MR with moderate MS with ejection fraction of 45%. So patient was started on anticoagulants, and bridging therapy for acetrom was started on day 7. So cardiologist advice were taken, and diuretics and beta blockers were added for rate control. So during the further course, on day 10, patient developed high-grade fever, and urine culture showed E. coli, fosfomycin, which was susceptible to fosfomycin, and chest X-ray revealed a pneumonitic patch. Patient was started on broad-spectrum antibiotics and antifungals. and there was a clinical and radiological improvement in X-ray within 7 days, and antibiotics were de-escalated. So over the neurological recovery, on day 15, patient started to follow simple commands like hand clasping. On day 40, there was substantial there was gradual recovery, and there was a substantial motor recovery by day 40, and the patient was able to mobilize with support. On patient was underwent intensive chest and limb physiotherapy and early mobilization. And the final plan was to maintain the patient on acetron with dose titrated to INR, diuretics, and beta blockers. On discharge status, patient was stable, following commands, and MRS score of 2 with slight disability, and she was planned for long-term neurorehabilitation. So this was my case, and now I will be discussing in brief about the 2026 HASA guidelines of acute ischemic stroke in relevance to this case. So,
Yeah, just before we go to the guidelines,
yes, sir.
it's a good case. Probably you have pulled out the patient from jaws of death in right time.
Yes, sir.
Because if you see the baseline NIHSS, which was 24,
Yes, sir.
sometimes what happens about 25, we don't consider IV thrombolysis. It's a relative contraindication. So
Yes, sir.
probably patient was just borderline. And even if you see hemorrhagic transformation, it
Yes,
is
sir.
just grade 1 or grade 2 in some area, so it is not significant.
Yes, sir.
And I don't think it would have affected any in the clinical outcome in any way. So these
Yes, sir.
two are the thing which we need to highlight. And poor compliance with the medication has costed the patient here. So that is another thing which we need to consider.
Yes, sir.
Dr. Madhusudan is there. Dr. Madhusudan, you want to say anything? You want to add something? Okay, so Dr. Madhusudan, there may be some technical glitch. So you just we can continue with the case and the guidelines. Then we will again take up questions. Go ahead, please.
Sure, sir. So I will be discussing in brief about this indication and contraindication and thrombolysis agent of choice, recommendations regarding concomitant thrombolysis and thrombectomy, and guideline recommendation for of endovascular thrombectomy for basilar artery occlusions, and the need for further research. This will be dealt in relation to my case. So, according to the latest guidelines of American Stroke and Heart Association, in adult patients who present with acute ischemic stroke with disabling deficits, regardless of the NHS score, and they are eligible for intravenous thrombolysis, faster treatment improves the functional outcomes. So, and this is a grade 1A recommendation. And in grade 1B recommendation, they have said that the treatment should be initiated as quickly as possible, and avoiding potential delays associated with neuroimaging such as CTA, MRA, or MR perfusion imaging. So even if you see in our patient, we first went with the CT imaging, which showed hypotensities, and then we continued with, we first did the thrombolysis, then we further proceeded with MR angiogram and MR imaging, then we went for thrombectomy procedure. So this is one thing that we should not wait for advanced imagings for initiating the thrombolysis, which is clearly noted in this guidelines. And as you know, in our patient had their history of rheumatic heart disease. However, she was non-compliant to therapy. So here in the guidelines, in related to our case, here they have mentioned that in patient without the recent use of warfarin or heparin, for in case of treatment with IV thrombolysis, it can be initiated before availability of the coagulation test results, but it should be discontinued if the INR is more than 1.7 or PT is more than 15 seconds or APTT is more than 40 seconds by local laboratory standards. So there is no definite contraindication. However, if the patient is already on warfarin, then it is contraindicated. For newer oral anticoagulants, they have mentioned that based upon, it depends upon the individual basis, based upon the risks and benefits calculation, we should decide on each patient basis. So this is one of the contraindication. So next, coming to the choice of the thrombolytic agents, according to the latest guidelines, Based on the phase 2 and phase 3 of multiple randomized control trials, it is now said that tenecteplase is preferred as the first line thrombolytic agent of choice, as it is easy to administer and bolus dose regimen can be given, which is time saving when compared to alteplase, which is given over a 1 hour infusion. So this is a grade 1 recommendation. Like in patient with acute ischemic stroke, within 4.5 hours, tenecteplase at a dose of 0.25 mg per kg body weight or alteplase is recommended to improve the functional outcomes. Multiple trials have shown that tenecteplase is equivalent and it is non-inferior to alteplase. As it is easy to administer, it is preferred as the first choice. However, previous recommendations and some studies of which showed that tenecteplase of dose of 0.4 mg per kg body weight is not recommended. It is 0.25 mg per kg body weight. So, in our patient who underwent both thrombolysis and thrombectomy, for patients who are eligible for both these procedures, it is considered safe and it is recommended to give thrombolysis before the thrombectomy, as it improves the overall reperfusion efficacy and clinical outcomes. So this is a grade 1A recommendation, and it should be administered. This thrombolysis should be administered as rapidly as possible without observation to assess the clinical response or delay in initiating EVT to improve the treatment times. These both are class 1A recommendations. So skip thrombolysis to facilitate endovascular thrombectomy. It is not recommended based on the latest guidelines. So it is both thrombolysis followed by thrombectomy. So in regard to the posterior circulation stroke, that is the basilar artery occlusion, before coming to the guidelines, we should know the PC aspect score. So PC aspect score is the posterior circulation Alberta stroke program early CT score, which is a score of total of 10 points, and 1 point will be detected if there is a hypodensity in the regions. So the regions are midbrain, pons, cerebellum, occipital lobe, and the thalamus. 2 points is given to the midbrain, 2 points is given to the pons, 1 point to the each cerebellar lobes, 1 point to the each occipital lobes, and 1 point to the each thalamus. So in our patient, there was a hypodensity in the midbrain and the pons area. So the score of 2 to the midbrain and 2 to the pons, and we should subtract 10 from it, and the overall PC aspect score was 6 in our patient. So this is important to know because basilar artery occlusion, as sir mentioned, baseline MRS score is important, not at presentation to the ERS. Baseline MRS score of 0 to 1 and NHS score of more than or equal to 10 at presentation, and PC aspect score of more than or equal to 6 of mild, which suggests of mild ischemic damage. This endovascular thrombectomy for basilar artery occlusion is recommended within 24 hours to attain better functional outcome and reduce mortality. So this was previously in class 2B recommendations. However, now it has come to the grade 1A recommendation that for basilar, even for the large vessel basilar artery occlusions, EVT is endovascular thrombectomy is recommended up to 24 hours. So in 2B recommendation, NHS a score of 6 to 9 and rest of the parameters are same. The effectiveness is of thrombectomy within 24 hours to functional outcomes and reduce mortality. It is still not well established. So this is the early randomized trials. It suggested a trend towards benefit, but it failed to prove statistical superiority of endovascular thrombectomy over medical management. However, recently 2 trials, that is Attention and BIOS trial, this successfully demonstrated that EVT is significantly superior to best medical management for acute basilar artery occlusions. The evidence now confirms the benefits of intervention in an extended time frame, specifically within 12 hours according to the Attention trial and up to 24 hours in BIOS trial from the symptom onset. So the guidelines is framed based upon these 2 trials. However, the further research must establish the role of endovascular thrombectomy in improving outcomes for non-basilar artery occlusions in the posterior circulation, such as vertebral and posterior cerebral arteries, and patients with low NHS score of less than 6 and low PC aspect score. and the preferred endovascular techniques for the posterior circulation also needs to be established. So these are the take-home points. So based now there is a preference on the latest, according to the latest guidelines, there is a preference for tenecteplase place based on multiple phase 2 and phase 3 randomized control trials. And there is a avoid skip thrombolysis, as they have mentioned. We should consider both thrombolysis and thrombectomy in the patients who are eligible for both the procedures. And there is a superiority of endovascular thrombectomy compared to the medical management for even for basilar artery occlusions, and it can be considered till 24 hours. There are extended treatment windows, and the careful patient selection is needed, which is a limitation. So these are the take-home points from the studies. So,
Yeah, that's a very good presentation, Dr. Bharat. So you
thank you.
covered most of the things which are relevant in the current context of IV thrombolysis and endovascular treatment.
Yes, sir.
As most of the tenecteplase trials were there, they were all non-inferiority design trials, because that time altiplase was the level 1 evidence, and against that everything was compared. Now
Yes,
I
sir.
think the jury is very clear. Now tenecteplase, which was there in class 2, has come to class 1, and it is now the standard of care in most of the acute stroke management pathways. That is one. Second is about the basilar artery. Though we have done in most of the patients, we have done basilar artery thrombectomy in almost wherever it was clinically indicated, but there was not much of a guideline to support. Suppose if the patient had worsened, we didn't have sufficient guidelines to back us up. But now thing is very clear.
Yes.
Third thing is about doing thrombolysis and then EVT. Some aggressive interventionists propose that patient come within 3 hours, you take them directly to cath lab without thrombolysis, you can open do a EVT. But that is not actually, that is even trials have not shown any improvement or any benefit compared to a patient who underwent IVT plus EVT. So IVT has to be considered wherever it is indicated. Only in extended window, probably you can take a call based on the situation. These three are the major key points which all of us should understand. Dr. Madhusudan is there. Dr. BK Madhusudan. Madhu, anything you want to add in this case?
No, I think it's a wonderful presentation what he did, Dr. Bharat.
Thank you, sir. Thank you.
What of the things he has covered regarding the endovascular procedures and all, no?
Yes, sir.
Now we are seeing a lot of flow diverters and those kind of things, right? Coiling with flow diverters and all.
Yes, sir.
What do you think the outcomes nowadays, especially in the posterior circulation?
So posterior, sir, actually the thing is posterior circulation in this patient, sir, like cardioembolic with atrial fibrillation, still the sir response to the procedures is still low, sir. According to the recent studies, and here also the practice is the response, like immediate response is low. Mostly on long-term benefits are good, sir. And compared to the anterior circulation, still, sir, posterior circulation response, sir, clinical response is bit inferior when compared to the anterior circulation, sir.
And recently we have seen some papers where the
Yes.
extended golden hour, right?
Yes, sir. Yes,
Extended
sir.
golden hour.
Yes, sir.
So what do you think about that? About that concept?
Guidelines, sir, actually they have mentioned like if there is a diffusion flare mismatch, then if the time of onset, that is the wake up stroke, 9 hours from the peak of the sleep, or like sir 4.5 to 9 hours if the time period is between 4.5 to 9 hours from the last well-known state, then even the patient can be considered for thrombolysis. And that recommend, sir. Sir, actually, thrombolytic, basically, sir, guideline, this extended window period, sir, it would be beneficial, sir, as more patient would be eligible for the thrombolysis. So, but like in, sir, but response to this, we have to see in future course, sir. Actually,
Okay.
now, till now, sir, we were practicing only for 4.5 hours. Now, based on upon the perfusion, we have to do with the perfusion imaging. However, sir, perfusion, according to guidelines, they have suggested if there is a penumbra, then we can consider for this thrombolysis, sir. However, CT
Okay.
perfusion imaging availability is also an issue, sir.
Sure.
In tips.
Thank you.
Do you follow MR based stroke thrombolysis pathway or CT based in your hospital, Dr. Bharat? SGPJ.
Sir, first, sir, MRI based, sir. First we do a CT, then we directly go for MR angiogram, sir. If at all, sir, MRI, if at all, sometimes if it is busy, then we will immediately consider CT angiogram, sir. Because
Okay.
sir.
See, most of the cases, most of the international trials are CT angiogram based trials.
Yes, sir,
But yes, if there is a deficit, if MRI is available, each hospital is free to design its own model. Number one. Number two, if MRI shows a diffusion restriction, probably you can thrombolyze even in the MRI gantry to save some time actually, some which we have done in many of our cases. So that is one thing. If BP is normal, if you find a diffusion restriction, probably you can stop doing MRI. You can continue you can give thrombolysis, continue the angio, and then you can take a decision on whether to go ahead with intervention or not. So you can save some time. And now if you see platelet, unless patient has a bleeding tendency, unless patient is on anticoagulation, you don't have to wait for PTINR, you don't have to wait for platelets. This is a very good, very boon. It's actually, I would say, for
Yes,
the
sir.
emergency physicians, because otherwise they had to chase the PTINR report, and we used to lose a lot of
Time.
golden hour actually. Time we used to lose.
Yes, sir.
So these are all the advantages what we have. So probably all the physicians should, at tertiary care or tier 2 cities now, IV thrombolysis is a standard of care. If you miss a if you miss a acute stroke in golden hour, it's a potential case for litigation definitely. So
Yes, sir.
probably everybody should assess the patient. If you don't have facility, fine, you can always transfer a patient to a higher center, but do not, miss the golden hour and later, land up in trouble. So that is the key message what we would like to, highlight. Any
Yes, sir.
question is there, moderators?
Question.
Uh-huh.
Currently, there are no questions, sir.
Okay, good. So then hopefully we had a good discussion about, IVT and endovascular therapy in acute stroke patients. So probably the baseline MRS is very important. Earlier age 80 years or 90 years age, they used to, people used to not thrombolize, but we have thrombolized a 96-year-old guy who walked home. So there is nothing, age is never a contraindication. What is more important is the baseline MRS. If baseline MRS is 0, 1, if patient is functionally independent, you can directly go ahead. And especially a patient like what Dr. Bharat treated in this case, NHS is almost 24. If you wouldn't have done, patient either he would have been dead or he would have been lived with a permanent disability, which is worse than dying. So probably, that timely management has saved a life. So this is the important, message what all of us as clinicians should understand. Develop your own stroke pathway in your hospital based on the resources what you have, based on the, infrastructure what you have, manpower what you have, and probably you have to apply for, complement the comprehensive stroke center and primary stroke center certification. Then if you are a neurologist, if that actually will add to your, add value to your service. Number one, more importantly, you will know all the protocols better, all the SOPs better. So this is the message what I would like to give in the end of this webinar. So if there are no more questions, I would like to thank Gennova team for giving us this opportunity and hand over the mic to the organizers. Thank you very much.
Thank you. Thank you so much, sir. It was indeed a very great case, and the fact that we could, reflect it with the current guidelines also gave our audience a very broader perspective of how practical the current guidelines are, as you very correctly mentioned. I would like this to take an opportunity to thank the course coordinator, Dr. Suryanarayan Sharma, our esteemed moderator, Dr. Madhusudan, and also a fantastic speaker for today's webinar, Dr. Bharat. Thank you so much for your time and for the incredible insights that you shared upon. And we look forward to having many more such sessions for our audience. Thank you so much, sir.
Thank you. Thank you.
Yeah.
Thank you. Thank you.
Thank you very much.
Thank you.
Thank you, sir. Thank you. Thank you.
Thank you.